Okay, we're now live. Hi, this is Elliot Fishman. It's July 10th. It's amazing how quickly July is moving. Hope you are doing well. Hope you're enjoying the summer. Hope the weather is not too extreme wherever you may be. Hope everything is good. The topic this week is actually on musculoskeletal CT. I think it's MSK month, so we came up with that. And if you ask me the question, MSK and CT, well, there's a long history. Remember, all the early work in 3D imaging, because of long scan times, fixed scan slices, everything was done in 3D with musculoskeletal. The original work was craniofacial, then trauma. We did a lot of work with acetabulum and pelvis. We did work with the knee and the ankle, all things where there could be relative lack of motion. Also, in the beginning of CT was the pre-MR days. When MR came along, a lot of the applications that CT was used for, MR could do better, particularly looking at soft tissues, muscle, tendons, ligaments, and the like. But there were still significant uses of CT. I would say trauma is the number one use, right? Patient has a motor vehicle accident. It's not necessarily a trauma, MSK trauma study, but it's multi-organ trauma, so you're looking from chest, abdomen, pelvis, thigh maybe. So you're looking for the presence of fractures, you're looking for the presence of muscle or soft tissue injury or vascular injury. There's some cool things we could do for bone. There are algorithms that straighten the ribs. One of the hardest things to me always has been counting ribs, particularly in a patient who's not lying perfectly straight, or one arm up, one arm down, or all sorts of issues. And also, rib fractures are commonly missed. With the new software, you basically, it's a central line through each rib. Each rib lit, left and right, is nicely defined. So it's easier to pick up rib fractures. That works very nicely. We also look carefully at the sternum. Remember, sternal injury makes you think of aortic injury. You don't need to have a sternal fracture for aortic injury, but aortic injury is usually related to significant trauma, and those patients will have sternal injuries. We also look at the clavicle, the first rib. You want to look very carefully in the abdomen. You look at the transverse processes, for example, L1 to L5, which are commonly involved, and particularly involved and associated with renal injury. So you may have isolated bony injury, but again, that will often be lower extremity or upper extremity. When it's the abdomen and you have injury of bone, there's often potential for multi-organ involvement, vascular involvement, and the like. Now, we also do dedicated exams, acetabular fractures, the extent of the fracture, preoperative planning, where the fragments are, looking for the presence of vascular involvement at the same time. And so the common areas will include the hip and femur. Common areas will include the knee and knee joint, and the ankle, particularly in fracture dislocations, as well as the shoulder. Now, there's no doubt that CT is better and more accurate than plain films, but it's especially valuable when it's complex injuries, right? When you want to know the extent of potentially with complex injuries, what's the involvement of vessel, what's the involvement of soft tissue, what's the involvement of the bone, and a single CT exam can give you all of those answers. So again, very, very important designing the protocols. There's a lot of stuff on CTisus going through that. If you want to see cases, go to CTisus, look up musculoskeletal, or look up trauma. We also do tumors. Now again, MR is probably the study of choice, but CT is very good for looking at involvement of ribs, any bone, looking at extent of tumor, looking at the marrow involvement with dual energy. Dual energy imaging especially is useful in myeloma, where you're looking for the extent of involvement, and we do these dual energy protocols from head to toe to look for the presence, and dual energy makes that fairly easy. Again, in terms of trauma, when we're looking at the potential of a vascular injury, particularly with a perforating injury like a stab wound or a gunshot wound, then the timing of CTA. Again, most of the time we're timing arterial, but you may need to get delayed imaging if you want to look for the presence of venous injury, which you may not appreciate on the arterial imaging, but easy to appreciate on the later or venous imaging. We find that 3D imaging still is very valuable, particularly at joint spaces, particularly with complicated injuries, as a guide for the surgeon for preoperative planning. And again, the complexity of trauma, as we mentioned, chest, aorta, chest, cardiac, chest, lung, abdomen, liver, spleen, kidneys, adrenal, bowel, putting all that together in a single comprehensive exam is very cost efficient, but also very time efficient. And in the ER and the trauma setting, time is of the essence. Again, you want to make the diagnosis quickly, so it's very important to look very carefully. A lot of work now is being done, and I've read a bunch of articles on AI in musculoskeletal. AI there's several different products on the market even that are better than or equal to expert radiologists in fracture detection. There are algorithms for tumor detection and classification that are said to be better than most radiologists. And then the whole area of AI in the involvement and prediction of management of patients is something that's coming along. Large language models can prove to be very helpful in this regard. Now let's see what else. We have a bunch of people on, a bunch of people will come back later, and we'll say hi to John from home. John, the printer's still not working, but theoretically they're sending it off. If you don't know what that means, you have to ask John, but hope everybody is doing well wherever you are. And I think those are the main things I wanted to talk about. Again, the other thing with musculoskeletal is looking at the soft tissue injury, patients with febrile necrotizing fasciitis, abscess, pseudoaneurysm, aneurysm, vascular involvement in trauma, infection, IV drug abuse. So we think about MSK imaging, especially in the ER setting, it is indeed extremely valuable. And we have given a bunch of talks. There's a few talks within the last year where I spoke about the ER setting with musculoskeletal involvement and how we plan and how we interpret and how we do things. So with that, I'll stop there. If you have any questions, you can ask me now. If not, ask me later. As you can see from here, there's 20 or 30 or 40 people on now. We have thousands of people who will look at the talk, but they will look at it at their own time. On the East Coast, it's noon, but no one breaks for lunch anymore. All our techs and docs are hardworking, and in Europe, it's dinner time. In China, the Middle East, it's time to go to bed. So we'll see you whenever you get here. With that, I want to thank everybody for their attention and have a great day.